Good afternoon again. We'll be beginning the session now. This is the third session for the day, titled Gearing Up for the Biggest Fight. The session is on drug resistance and expensive drugs. The session will be chaired by Dr. Suman, who chaired the first session as well. For those of you who came in a bit late, I'll introduce Dr. Suman again. He's the director for DNDi office in India. He has experience in the field of tropical and infectious diseases and a huge experience in the field of Kala Azar. Dr. Suman, can I kindly request you?
Thank you for the kind introduction. Welcome back to this first session after the lunch. I know it's going to be difficult, but I'm sure that you'll be delighted to have these three talks. Now, before I invite the first speaker, I'd just like to briefly introduce you. So, as all of us are aware, antimicrobial resistance and its consequences are a big public health challenge. And it's not only for the health sector, but in the development sector as a whole. I mean, just to quote a few facts, currently AMR is responsible for around 700,000 deaths. And if this is not tackled, it could lead up to 10 million deaths by the year 2050. Now, it also has its consequences on attaining many of the targets of the Sustainable Development Goals, because it is going to have also a huge economic burden in addition to the health burden which we are going to face. Now, it's not a small problem or a disease in itself, because it involves the effect of AMR, or the consequence of AMR are basically when we have used excess amount of antibiotics or irrational use of antibiotics. We all think that's the cause. But then if you try to reflect, this could be starting from in the manufacturing of the antibiotics. If the effluents from those pharmaceutical industries are not processed well, and if they're let out into the the rivers and the streams, that could itself lead to a lot of resistance. It could be the quality of the antibiotics which is manufactured and which is being used, that could also be responsible. Then the use, not only in the health sector, irrational use, or which we say excess use, but also in the other sectors, for example, the poultry sector, and even in the fisheries. So this is a huge problem if you look at it from the dimension of but then there has been a revival of efforts. There was the global action plan on AMR, which was brought on by the WHO in 2015, and which tries to take into consideration how we tackle the different sectors and working in a multi-sectorial approach. Now, a bit on why I'm sitting here today. In the morning, I was in the neglected disease session on Kala Azar. Well, Drugs for Neglected Disease Initiative in 2016, as part of our business plan, we incubated an organization that, I would say that time it wasn't an organization, it was a project that would try to look into the AMR space together with WHO. And we have incubated this organization called GARDP, Global Antibiotic Research and Development Partnerships, which is now a separate independent entity in itself. And GARDP has started work looking at few of the areas in AMR. So it has basically tried to look at the priority pathogens which has been identified by WHO, and also taken into consideration the needs of the developing countries. The model is very similar to what we do, is working in partnerships. So I'm sure some of you who are working in the AMR space, you will have an opportunity to interact or work together with GARDP, because GARDP is very actively involved working in India, especially in the next few years. So this is with the brief introduction to the subject, and I will then, without much hesitation, would like to invite Dr. Amit Harsana, who is the Medco from OCBA, who is going to present the first paper. Now, Amit oversees the work of HIV, malnutrition, and NTDs. He has been primarily involved in the implementation of numerous operational research projects for MSF here in India. Prior to joining MSF, he worked within the WHO and the Ministry of Health, India, as a technical advisor for various national health programs. He's a medical doctor who graduated from South India and then specialized in preventive and social medicine in New Delhi. I invite Amit to give his talk.
Thank you, Dr. Suman, for such a kind introduction. I think the stage and these the context has already been set by Dr. Suman by giving a great talk on what global platforms are thinking about AMR and how it is important to think about antimicrobial resistance. So to start with the presentation, what we have is it's a mixed method study which was done in West Bengal, and if you look at the topic itself, it's a quite a provoking one, which is without antibiotics I cannot treat. So we have gone through the quite good number of challenges what clinicians are facing, and also from the perspective side of patients' care. What do patients feel? This is so from the both sides we need to understand why and what we need to kind of prescribe. So giving the introduction. WHO has already warned that a world is entering into a post-antibiotic era. What that means is, in coming times, we fear that some of the minor infections would also be kind of become such a tough one to treat that we won't have antibiotics for them. And then, if you look at the global reports from 2010 to 15, we have seen the daily consumptions of antibiotics has gone almost 65% higher from 2010 to 15, and the major bulk is low middle income countries. So it's a great increment in the number of antibiotic prescriptions, and that's why. And if you look at antibiotic resistance as such, it increases your healthcare cost because it increases your hospital stays. It increases your treatment regimens, and definitely because there is a higher prescription load of advanced antibiotics. The objectives of the study was to understand the public perceptions and vocabularies of illnesses regarding antibiotics, and to understand the knowledge, attitudes, and practices among the provider side. So you wanted to understand what is the provider's perspective, and then definitely from the patient side, what do they think about, why do they need antibiotics, and definitely to understand the overall drivers for prescription choices. And now, regarding the methodology, it was a mixed method study, sequential design, so it's a mixed bag of qualitative and quantitative study. We did 384 cross-sectional surveys. It was a purposive convenience sampling, and if you look at the numbers of surveys, it was divided among 96 doctors, 96 nurses, 96 pharmacy workers, and 96 informal healthcare providers. And also along with that, we did in-depth interviews, and the number was 28, and 21 were healthcare providers, and 7 were patients, distributed among all the different administrative blocks of a particular district of West Bengal. And then the survey data was collated in Excel and analyzed in SPSS. And qualitative data was analyzed using the framework method. I'm not going deeply into the methodology or the analysis part of the qualitative study. It was coding and thematics in rows and columns. One question which probably, one thing to highlight here is like, we have got 96 pharmacy workers, and that's also pretty interesting, which also sets the context, because we didn't write pharmacists because we all know that a lot of pharmacy shops around the corner or in India as such are not being owned by licensed pharmacists. So, I mean, if you do not have licensed pharmacy, if the pharmacists are not having license, but still there are several shops you can find, you can simply go and buy antibiotics and then, or any other drugs, and these shops are owned by any layman for that matter. So that's why the term is 96 pharmacy workers. A bit about the demographics and the background population. You would see that among the doctors, so the mean age of the survey was like, you can see 42 years. There's a bit of deviation towards when you look at gender. Doctors, 80% males. Informal providers, 99%. Nurses, 96% are females. That's because, again, that talks about the background population of where we were doing the study. So because by the nature of you get only informal you get only male informal providers, and maximum nurses you will find in the primary health settings females. The survey results. This is where the most of the discussion are going to be around. So one thing which is pretty interesting and pretty kind of alarming also at the same time for us is when you look at the knowledge. Definitely the knowledge among the doctors is good. That so we had a questions which is coming to the next slide. So we'll talk about this and then we'll go back to that slide. So the question was, antibiotics are useful for viral infections. Now the question, I mean, if you look at the knowledge, most of the doctors are saying, I mean, they're strongly agreeing to the fact that antibiotics are not useful for the viral infection. So it's a flip of a question. So knowledge is there, but when you talk about practices, you'll see that many of the doctors are actually prescribing antibiotics. So we'll have to find out what are the reasons. I mean, that's where the qualitative study falls in. Like, what are the main drivers? Why doctors, despite having a good knowledge, they're still prescribing antibiotics? And this is what we found in this qualitative study. And if you talk about the knowledge for all other providers, which is informal healthcare providers, nurses and pharmacy workers, yes, they didn't have much of a knowledge also that antibiotics are useful for viral infections. So if you see this, doctors had comparatively better knowledge, as I said before. But then again, let's look at the practice. More than 80% of the doctors, and definitely more than 85% of informal providers, they gave antibiotics for cold. I mean, so more than 80% of doctors prescribing antibiotics for cold. I mean, it's still something which is worrisome for us. And then attitudes between providers were very similar, because it is more related to the questions. Because for attitudes, it was like, do you think antibiotic resistance is a problem? Do you think you can combat antibiotic resistance? So it's a more general kind of questions. That's why you get good score in that. And then if you see 30% of all providers and 58% of all informal healthcare providers, they relied on pharmaceutical company representatives as a source of knowledge about antibiotics. I think this is also one of the points which we have to think about. I mean, if the primary source of knowledge is pharmaceutical company representatives, so there's definitely a bias we see here. And the scoring of the CAP survey, we used Likert scale. 5 was given for the most accurate answer, and 1 was for the least accurate. And then the composite scoring was done for knowledge, attitude, and practices, and the average percentage score was calculated. And let's look at the average percentage scores here. I mean, you would definitely see in the knowledge, allopathic doctors are far better, definitely, because I mean, as compared to informal healthcare providers, nurses, and pharmacy shopkeepers. Attitudes, as I mentioned before, you would see they're fairly doing good in attitudes. But when it comes to practice, let's see, like 67% of the doctors are having a lower score in practices when it comes to antibiotic prescriptions. But also at the same time, we would see informal healthcare providers, nurses, and pharmacy shopkeepers are having fair, percentage in practice. This has to do with some social desirability bias, because they know they're not supposed to prescribe. I mean, just to note, I mean, all informal healthcare providers, nurses, and pharmacy shopkeepers, they're not supposed to prescribe antibiotics. It is clearly written in the Drugs and Cosmetic Act of India that it is illegal. But I mean, that's the reality. They still do prescribe antibiotics. So that's why I think for the if you see the score in practice, you see a little higher number because they know that they're not supposed to prescribe. Now coming to the most interesting part of this, like why doctors or like for any of the matter why patients are asking for antibiotics. So I mean the question is patients demand for quick cures. And that derives irrational antibiotic uses. I mean, but also that's a question for doctors. I mean, if only patients are asking for antibiotic, that doesn't mean that doctors start prescribing antibiotics. But why it is happening? It is still happening. So, there's a quotation from if you see most of the patients ask for antibiotics. They think antibiotics are the main treatment. I mean, that has gone down so deeply in the community as such that for many a times. From the patient side and from the testimonies, what we have received is the patient going to pharmacy shops and asking for. So some of the patients, they would even know the name of the antibiotics. So you would ask for amoxicillin for cold. I mean, if you can ask for amoxicillin and that too for cold, I mean, it's still, I mean, so knowledge is there, but I don't know what kind of a knowledge is this. So this is where I mean, where is this information coming from? So if you look at the setting of, there's a difference in rural and urban setting in India. So if you go to the rural setting, what are your primary contacts? So your primary contacts are generally your informal healthcare providers. And this is where, I mean, if one of the recommendation probably through this should be that we have to let the community-based antibiotic stewardship programs. And what do we mean by that? If we have primary contact points, which are your informal healthcare providers, and their knowledge is deeply kind of influenced by pharmaceutical company representatives, so you know what we're talking about. So, and definitely they do not have the knowledge about when do they prescribe antibiotics or when is actually the ideal time to prescribe antibiotics. They do not know the differentiation between viral and bacterial. But the question is, why they're still there? I mean, it's there everywhere, not just about rural India. I mean, if you go to the urban India, you go to any of the outer skirts of any city, big city, you'll find these informal healthcare providers which are prescribing or like simply kind of rushing with antibiotics. Now the thing is, the biggest problem probably what we have in front of us is just taking you to the public health standards of India. So we have got one nurse care. I mean, we have got one nurse midwife for every 5,000 population. And the reality is that sometimes these ANMs, they go to these informal healthcare providers, they ask for treatment. So, I mean, somebody who's 8th standard or 10th standard educated, but then again, your ANMs are going to them and asking for, can I have some treatment? So this is where I think the most challenging part is. I mean, yes, hospital-based antibiotic stewardship for sure, but we are missing hugely on community-based antibiotic stewardship programs. Then antibiotics are provided to prevent against secondary infection. So this is again coming from a medical doctor that if my patient is having viral infection, then I prescribe on prophylactic basis antibiotics because I think that a patient is going to have secondary infections, and it's better to provide antibiotics, so that I have already done something, because it's also linked with your income generation. I mean, your doctors, you don't want to lose your patients, so patients also want quick cure, and also the doctors also, they want this, like, as many as possible, you give antibiotics, you give n number of medicines, so it becomes better. This is what they think. So it's all like, it's kind of linked. And definitely because they also have this the feeling, doctors have this feeling that because there is a lack of adequate testing facilities, so because I do not have enough of laboratory services, I do not have enough of aseptic conditions in my hospital, so I think it's right to prescribe antibiotics on the first place. So if they think like that, because and also because the patients, when they come to these settings, because there's a long queue, they do not have time to see the patients. So it's a multifactorial approach. I mean, there's a long queue because, again, these patients, those who are coming to these government setups, we're talking about mainly about the government setup here, because private setups, we've already touched upon how informal healthcare providers are ruining this kind of practice-based approach. And then there's a long queue, the doctors think that because they have to prescribe antibiotics because otherwise they lose the patients. So that's the reality. Yeah? And definitely the pervasive influence of pharmaceutical company representatives. Yes, I mean that's so the primary source of knowledge for doctors and for the informal healthcare providers. If it is pharmaceutical company representatives, then definitely they'll sell out whatever they need. Yeah? And then again, one of the things which we noticed was 3-day course of antibiotics due to poor follow-up and perceived lack of adherence. And also, it is coming from many of the patients that why do you, I mean, can I have 1-day course of antibiotics so that I can become better? I mean, so 1-day course of antibiotic, so definitely, yeah, we know that if somebody asks for that, then what do doctors do? I mean, probably they will also say, okay, you take 1 day of antibiotics and you'll be fine. But then that's not the right thing to say. And also, so some of the things which we got, I mean, this is something which is pretty interesting. Huh? From the healthcare providers, we also noticed that there was a term called halka-fulka antibiotics. What does it mean is, so they do have this hierarchy, which is low power antibiotics, high power antibiotics. So amoxicillin is like a powder for them, and then you have got amoxiclave, or you have got any other higher antibiotics which is stronger and low. So it is okay to prescribe these halka-fulka antibiotics for any of the patient, even if they're coming with viral or any constitutional symptoms. So that has become a habit. I mean, if that, and that's main with your informal healthcare providers, just to mention. I mean, more not with this particular behavior is more with your informal healthcare providers, because they're not trained, they do not have much of differentiation between viral and bacterial infections. And then the interdependency between doctors, informal providers, and pharmaceutical company representatives. I mean, again, this is the true thing which is present. So we have got informal providers, those who would provide the patients to doctors, and doctors would blame informal healthcare providers for increasing resistance. So it's like, this is a closed circle. And that's more or less what we talked about. And this is one of the table for one of the hospitals. So you can see, I mean, the pharmaceutical company representatives, they give free samples and the knowledge. And that decides, or that derives, that takes you to what antibiotics you have to prescribe. And if that is the source of knowledge, then definitely we are failing somewhere. And yes, and the thing which we wanted to focus here was that we definitely need to work on patient's perception, relationships between different providers, and the role of pharmaceutical company representatives. Thank you.
Thank you, Amit. It was a very interesting, I must say, perspective, and I'm sure we'll have lots of questions in the discussion, which will be at the end of the 3 talks. Now, I would like to invite Dr. Farah Naz Hussain, who is recently joined as the Medco of OCB here in India. She's a medical doctor with a master's degree in public health. She has more than 10 years of experience working with not-profit organizations in developing countries in Asia, Africa, and Middle East. She had been coordinating the country medical activities MSF for 6 years and has worked with MSF on antibiotic stewardship activities in Iraq. So, Dr. Hussain, please could you come? Yes, thank you.
This is a short people problem. I have to raise this down. I'm going to talk about the patterns of antimicrobial resistance from a post-op care program in Mosul, Iraq, which is a post-war context. So we all know more or less what is antimicrobial resistance. So we introduce an antibiotic in the system of a human being or an animal. And then some of the susceptible bacteria, they will die, but some grow some resistance. So they fight back. And then they submit to their offsprings that resistance pattern, and then they become resistant, and their antimicrobial resistance comes in. It is called the silent tsunami because a lot of us are not really aware of it, and so far now we are waking up, but it is like a tsunami that is growing, and we have to be careful. So it not only increases the mortality and morbidity, but as Amit was saying, it also increases the economical cost, it increases your hospital stay, you need an antibiotics which is higher in strength, and of course it's more expensive. And then you stay longer in a hospital, you're not earning anymore, so you're also losing money. So someone else before who was talking about the environmental impact was talking about more or less the same thing. As humans have been taking antibiotics so granted, we have been misusing and overusing antibiotics for decades from the time it has been introduced to us. So inappropriate usage of medicines, it is worsening the drug resistance. Poor infection control among ourselves in the hospital setting or within ourselves, it can also lead to drug resistance. The weak surveillance system that is more or less non-existent or maybe somehow is there but not working is also contributing to the spread, because if we do not know what is spreading in the environment, then we cannot control it. We did talk a little bit about DNDi and the initiatives, but the pipeline so far with antibiotics, new antibiotics, is more or less dry. So WHO has started this surveillance system. It's called the Global Antimicrobial Resistance Surveillance System, GLASS. So they had this report out in 2018 in Bangkok, and it said across 22 countries, 500,000 people had some sort of antibiotic resistance. It is a global problem because pathogens do not respect borders. They will not need a visa. So if something is in Iraq, it can come to anywhere, say Brussels, Belgium. Now, a little bit about Iraq. OCP, the French section, they did a small survey among the patients that were admitted in the Jordan hospital. They did find out the Iraqi patients who were admitted there, their gap was existing in their knowledge level. Antibiotics in Iraq are available over the counter, and there is no legislation existing anymore. Lack of data is there with current resistant pattern. The Iraqi government did plan a draft national plan for multi-sector road mapping aiming at preventing and controlling the antimicrobial resistance, but it is still in a draft stage. I was just talking to one of the doctors that we had in the hospital, and then he just said the war changed everything. Before 2003, there was more law. We could not buy drugs over the counter, but then there was ISIS, then there was the war, and then hospitals were more or less non-existing. Doctors were running away from the country. We had no choice. We had to buy antibiotics wherever we could because there was nobody to take care of us, even in the hospital. So the pharmacies were the only place we could get some treatment. So the war in Iraq changed everything. Now, Mosul. Mosul is in the northeast of Iraq. It is located 400 kilometers away from Baghdad. It is the second largest city in Iraq, and the river Tigris runs in the middle and dividing it in east and west. The West Mosul is basically the older part of Mosul, where it was more or less the place for ISIS. And West Mosul was the most hard-hit area. But before that, before the war, West Mosul had a very good health system. All the tertiary care health centers were located in Mosul, West Mosul, and they had specialized services, and all from the district that is where Mosul is, all over, the population came in West Mosul seeking treatment. A little bit of, and the battle for Mosul was running between October 2016 and 17 with an estimated death toll of 9,000 to 11,000. 2 years after, even though the war has finished, still there is sporadic attacks. There are small bomb blasts. There is still IED in West Mosul, still not cleaned up. And we see patients who are still coming, children who are were playing outside, and then one IED blast happened and they're in the hospital. Bit of picture of Mosul, what it looked like before. This is the health complex, and there was a 5-star hotel. And just to show what happened there, this is what it looks like now. Everything is gone, everything is on the ground. There is no more hospital, there is no more tertiary care existing in West Mosul that was supposed to be the best in Middle East. MSF started a post-operative care center in April 2018, providing the services in Mosul with reconstructive surgery, post-op care, rehabilitation, pain management, and physiotherapy services. Our facility consists of one OT, that is in a mobile surgical unit. Because of emergencies, we developed a mobile surgical unit which could move everywhere and provide services to the population. We have a 30-bed inpatient ward with 11 isolation capacity. These are self-contained rooms for infectious cases. Why we wanted to do this intervention? Because almost 21,000 people were wounded during the Mosul battle. The health actors were only interested in emergencies, and then they left after the war was finished. And the hospitals, which were more or less destroyed, did not have the bed capacity to take care of even fresh cases, and nobody wanted these chronic cases. So these people who were wounded during the Mosul battle had not been healed, needed reconstruction, needed care, did not have any place to go. So think about the humanitarian cause of it. One of our patients, I can remember, who had an external fixation, his whole family has been killed, and he was living in his neighbor's house outside their house. They gave him a space. And then he was the only earning member. He was in our hospital receiving a 6 weeks third-line antibiotic, and on the second week he refused to continue his treatment. He had an active infection and he did not want to continue because he was the only earning member, and he had to go back to his family because there was no food at home. So we wanted to formulate an efficient AMR control plan because it is not always possible to treat everybody, and it is also crucial to have a clear view on the current pattern of bacteria resistance of the patient who are admitted. We also did not have a lot of space. We wanted to know who to isolate, who to not isolate, who gets a bed in the IPD, who gets a bed in the isolation ward. We wanted also data to sensitize the community. Like Amit was saying, community sensitization is needed. We wanted to prove that this is a problem and this is existing. So the aim of the study was to describe the current status of the antimicrobial resistance in the infected patients admitted in MSF CPOC Comprehensive Postoperative Care Hospital in Mosul, Iraq, between April 2018 to December of the same year. It was a retrospective descriptive analysis and from the routinely collected data of the surgical ward and HUNATE microbiological database. The objectives of this study was to describe the demographical clinical characteristics of the patient, determine the overall resistant pattern of the bacteria isolated, and describe the detailed antibiotic susceptibility pattern in subsample of patients with MRSA and expanded spectrum Betalactamase ESBL positive. So Betalactamase is an enzyme that is present in the bacteria that can attack the ring that covers the antibiotic and make the antibiotic not work anymore. For the patient characteristics, 194 patients were admitted between this period. 25% of them had osteomyelitis, which is a chronic infection of the bone. 134 underwent primary intervention. To notice that 87% of this patient were admitted because they had injury from a violent trauma, which are basically bomb blast injuries, mine injuries, gunshot injuries. The median age of new admissions was 27 years. Young population were the ones affected the most. And the median length of stay, even though they could stay up to more than 1 month, the median length of stay was 7 days. So 188 samples were taken from 71 patients. 84% of patients had at least one positive sample for growth. Majority of the samples were tissue and bone. 182 isolates were recovered from the samples. 54% of them were gram-negative and 40% of them were Staphylococcus staph aureus. 92% of the Staph aureus isolates were methicillin resistant. I'm sorry, this is a lot of jargon, but what to take home is 82% of the samples who had a positive growth were positive for MDRO, multiple drug resistant organism, 82% of all of them, which is a very high percentage. This is what comes later. So we also tried to see if there was other data available from similar studies. We kind of found for the similar population, there was not many studies available to see the antimicrobial resistant pattern. We did find some information on the military population. Basically, it started from when we came to know that American soldiers were dying, who were working in Iraq, and some study data was available from there. There was also a knowledge, attitude, and behavior survey done in similar population who were admitted in OCP, the French section hospital in Jordan. There was similar prevalences of ESBL found in ICU population, in ICU patients, and MRSAs reported in other studies. So as conclusion, we can say we should be able to start up-to-date local knowledge of resistance in the general population with this data, and also to create an evidence base to develop more strategic studies. This was a retrospective study of routine data, but we can plan more strategic studies in post-war settings for civilians. This also provides data for us to improve empirical treatment guidelines and encourages for us to improve infection prevention control in our setting. This is also something that we were wondering because we did not have a lot of isolation capacity, nor does the government have it, because you cannot isolate every patient. So we were wondering if we should do screening of MDR carriers when they're coming to the hospital. This can be an option. We also have an antibiotic stewardship program, the knowledge of which we should be able to share for training of staff and continue. We also can use this data and information for sensitization of the community and also to use for national level for advocacy on planning of ABR control and maybe to push for this draft guideline to be finalized so that the plans are implemented. Thank you.
Thank you very much for this presentation, and it was really touching to see the initial picture of Mosul and what has come, and I mean, I was just wondering if we could have prevented that. That would have been a huge, achievement there. So before we ask the questions again, we have the last speaker, and I'd like to introduce Professor Peter Wickerman. He's a professor of infectious disease modeling at the University of Bristol. Originally trained as a mathematician, he had a DPhil in mathematical epidemiology and 20 years experience in modeling infectious diseases. Professor Wickerman has contributed to many international advisory groups, including WHO, UNAIDS, NICE Public Health Guidelines committees, the UK Advisory Council of the Misuse of Drugs, the European Monitoring Center for Drugs and HCV Treatment as prevention working groups. His research focuses on the use of modeling to help understand infectious disease transmission, especially blood-borne viruses, and the impact of cost-effectiveness of preventive measures, including within high-risk groups such as people who inject drugs and female sex workers. So he's going to move from AMR. We're going to talk on hepatitis C virus modeling. So I just want to say something about hepatitis C virus. In the last few years, 4 or 5 years, we have seen a paradigm shift in the drugs which are being made available to treat HCV. But at the same time, there has been a challenge to access these treatments because of the cost, and also because the way we have been treating hepatitis C is in very specialized centers. On the other side, if we want to see the usefulness of this drug to decrease transmission, there has to be an exponential increase in the number of patients who are being treated so that we can bring the infection in the prevalence in the community to come down. So modeling has been one of the key ways to help us and guide us as to how we should be approaching our approach to these treatments of this disease, especially from a community and a public health approach. And I'm very pleased that Professor Wickerman is going to present something here today. Please.
Hello, thank you for inviting me to come to talk today. So I'm going to be talking about some work we did with Médecins Sans Frontières linked to a multi-country study they were doing, partly funded by Unitaid. So I prepared these slides with Josephine Walker, who also did some of the work in some of the settings. So we've already had a bit of an introduction about hepatitis C and the new treatments. Hepatitis C is a blood-borne virus transmitted through a number of main modes of transmission. In developed countries, it's generally through injecting drug use. And elsewhere, it's also due to unsafe medical injections and medical procedures, and also non-sterile barbering, ear piercing, and tattooing. So in 2015, it was estimated it was about 71 million people infected with hepatitis C virus globally, with about 400,000 deaths annually. And most of those infections, about 80%, are estimated to be in low to middle income country settings. And in those settings, less than 5% are estimated to be diagnosed. So in 2014, the sort of treatment landscape for hepatitis C really changed. There was a number of drugs that came on the market that meant it was easily treatable with an oral regime, with cure rates of about 95%. But the problem was, at first, it was expensive. The drug costs have decreased quite dramatically over those recent years, and in some places they've become pretty cheap, to about $50 per course in Pakistan, but then in other places, such as the UK, it still costs £10,000 to treat one person. Because of these new treatments, the World Health Organization developed elimination strategies for hepatitis C. They wanted to reduce incidence and mortality by a large amount by 2030, but to achieve this, we need to scale up testing and treatment, which hadn't traditionally been done much in low and middle country settings. So what happened, what I will be talking about today is this large multicentric study which MSF undertook in a number of different countries, partly funded by Unitaid. So this was a collaboration across a number of different MSF centres and also the Access campaign. And it was also a collaboration between the University of Bristol and Imperial College London. Over the 4-year project, about 70,000 people were screened for hepatitis C in a number of different countries globally. 20,000 people were diagnosed, and about 10,000 people were put onto hepatitis C treatment. And across those 10,000 people, they achieved a cure rate of about 96%. So within this study, we were in charge of doing the economic analyses to see whether these interventions were cost effective. And this was seen as an important component to try and understand whether these interventions could be generalized to other settings for governments to scale up in their countries. And we did analyses in 4 different countries, in Cambodia, Pakistan, Kenya, and Myanmar. And the next slide describes the main characteristics of the interventions in these 2 places. So in Cambodia, it was an intervention in Phnom Penh, and this was they set up a hepatitis C clinic in a public hospital. In Myanmar, in Darway, they initiated hepatitis C testing and treatment within an existing HIV clinic. In Pakistan, in Karachi, they initiated hepatitis C testing and treatment in a primary care clinic. And within this clinic, they they tested only people which they thought had risk factors for hepatitis C transmission, and they prioritized treatment to those with some form of liver disease. And lastly, in Kenya, in Nairobi, they initiated hepatitis C testing and treatment in a harm reduction drop-in center for people who inject drugs. And here they undertook directly observed treatment because they thought there was going to be possible issues of adherence amongst this population group. Now, in all of these places, the model of care that was used was generally similar to what WHO guidelines suggest. Although in Cambodia, after a certain amount of time, they started transitioning to a simpler model of care to try and increase the number of people they could treat. So this slide describes the two main models of care that were used. So across the four settings, they all started off with this full model of care or something very similar to this. So this had a lot of visits, 8 visits before they start treatment, where there was lots of tests, including the hepatitis C genotype test, which is quite expensive, hundreds of dollars. And then following the start of treatment, they had about 8 different visits as well. So hepatitis C treatment generally lasts about 3 months, and they were having about 8 visits after the start treatment. And many of those involving a clinician and blood tests. Now, Cambodia, after the first number of months, they started transitioning to this simplified model of care, where the number of visits was halved. So they went from about 16 visits to about 8 visits over the whole period, with fewer use of clinicians and less blood tests, including no genotype test. So this slide shows some of the characteristics of what screening and treatment was done in the different places. So if you look within the red square, you see that Cambodia and Pakistan did the most screening, about 15,000 people screened in both of those two places, with less so in Myanmar, about 5,000, and about 1,500 in Kenya. Now, in the different places, they also achieved different yields or different levels of positivity for hepatitis C amongst those people that they screened. And surprisingly, the highest level of positivity was in Cambodia and Pakistan, which were actually interventions that were screening a general population, whereas in Myanmar, where they were screening HIV positives, and Kenya, where they were screening people who inject drugs, they got a lot lower positivity of around 6%, whereas in Cambodia and Pakistan it was 35 to 40%. And the thought is that in Cambodia and Pakistan there was a lot of people coming to get tested because either they had been tested before but they couldn't get treatment, and now they knew they could get treatment at this place, or it was people that had existing risk factors that they thought they may have hepatitis C. When you look at the number of treated, similarly to the number of screened, there was more treated in Cambodia and Pakistan, 1,500 in Pakistan and 4,500 in Cambodia, and about 100 were treated in Myanmar and Kenya. And lastly, I think important for the next set of results is that the cost of treatment was highly variable across the different places. So this is the cost of the actual drugs for treating hepatitis C, and it varied from about $500 per course in Myanmar down to $700 in Kenya, 500 in Myanmar, down to about 120 in Cambodia per course. So the main aim of what we wanted to do was evaluate the cost effectiveness of these interventions, including the testing component and the treatment component. In each of these places, we compared it to them doing nothing, because there wasn't really much testing or treatment occurring in these places before these interventions occurred. We estimate impact in terms of QALYs and DALYs, which people normally find a bit hard to understand. So a QALY, one QALY, is 1 year of perfect health. So if you save one QALY, you've saved a year of perfect health. If you save yet 1 year of life, but the person feels pretty bad, then that'll be worth less than 1. It'll be, say, 0.5 of a QALY. Disability-adjusted life years are a bit like QALYs, but the opposite. So if you want to avert disability-adjusted life years, 1 disability-adjusted life year is losing 1 year of life. So within our model, we model the healthcare costs and we model the outcomes, and we model that over a patient's lifespan. So if you treat someone, there's the costs of treating and testing that person, but there's also, you're going to hopefully have benefits in the future. That person might not get liver disease. You may avert healthcare costs of them having a liver disease, and you try and incorporate that into all of that into one model. So how many health benefits do you get, and how much did it cost, but how many costs do you avert in the future? Saying that, we discount as well. So we want to, things that we pay for now are more important to us than things we maybe pay for in 20 years' time. Or benefits, health benefits we get now are more important than health benefits 20 years in time, because who knows what will happen in the future. So we have a discount rate that's to devalue things in the future compared to things now. And in terms of how we estimate the cost effectiveness, there's this thing called the ICER, or an incremental cost effectiveness ratio. And what that is how much are you paying for each added benefit you get? So how much are you paying for each QALY you save, each year of life you save, or each year of life lost that you avert? And that's how we estimate cost effectiveness. So in terms of the model, we had a model which captured the cohort of patients in each place. And so we got the patients in each place, and we put them into this model, or simulate them in this model, and look to see at what liver disease progression they're likely to get into the future, because we don't know that yet, and that's what the model's doing, is trying to simulate that possible future. Within that model, we have a proportion of people in different stages of liver disease that we treat, and we use data from the studies to do that. So we say these people were treated. And if those people are treated, then the model, there's less liver disease progression, so they get less ill and you get health benefits. Now, this model uses data from the intervention in terms of who gets treated, what was the levels of liver disease of these people initially, but it also uses data from the literature on rates of liver disease progression for hepatitis C and rates of death from hepatitis C. Importantly, for Kenya, we also had a transmission component, because in Kenya we were treating people who inject drugs. They're more likely to transmit hepatitis C to each other. So if you treat one of those people, you may stop them infecting somebody else, or somebody else getting infected. So there's a possible prevention benefit. So in Kenya, we try to incorporate that into our model. We also estimated costs from the different interventions, and how we did that is we looked at what happened in the testing and treatment pathway, and we costed the activities in those different points of the treatment pathway. So it's screening, we look to see what happens at screening. Maybe you see a doctor who takes a blood sample, it gets sent to the lab, gets tested. Maybe there's a bit of counseling or risk reduction counseling, and we cost all those different elements. We include staff costs, overhead costs, lab costs, test costs, and medicine costs, such as for the hepatitis C treatment. We then look at how that varies by patient. We add it all up for a patient. So how much did it cost for that patient to go through treatment and testing? And that varies by patients. Some patients have more visits than others. Some have more tests than others. So we get sort of see how much it costs per patient. So this gives some of the results of our analyses. So this looks at how much it cost per person that went through treatment. That's the first figure at the top, and the figure on the bottom looks at what were the main components that made up that cost. Now these costs in the top figure also include the costs of diagnosing somebody to get them on treatment, except in Myanmar where we didn't have those costs. What we first see in the bottom figure is that the drug costs, the DAA costs, the DAAs mean direct-acting antivirals, which is the sort of classification of these drugs, was the main component of, or the largest component of the costs for the treatment, which is shown as the red elements of these bars. However, the place that this wasn't the case was in Kenya, where they were doing directly observed therapy, which was the largest component of the costs. When you look at the actual total costs of treatment, you see that Myanmar and Kenya have the highest costs. And this was due to the direct observed therapy in Kenya, but also the higher drug costs in these two places and the higher lab costs in these two places. It's also important to note that in Cambodia, where they transitioned to this simpler model of care, they have by far the lowest treatment cost of about $300, which is nearly a tenth of what it is in Kenya. So this shows the incremental cost and the incremental benefit per diagnosed patient. So for the cost, this is slightly different than the previous slide because it now incorporates any health care costs averted, although we only had data on this for Cambodia and Myanmar. So now if you look at the Cambodia simple model of care, it's actually, the cost is actually negative now. So what this means is that when you take into consideration the cost of healthcare averted, it actually saves money from diagnosing and treating people in Cambodia. Oh, 1 minute. Okay. Whereas if you look at Kenya, they had the highest cost of treatment and diagnosis, but they also had the highest benefits, because that's the prevention benefits of treating people who inject drugs. Now this slide shows the cost-effectiveness projections. So if you look within the red square, we show the incremental cost per DALI averted or QALY saved, and we see that the incremental cost-effectiveness ratio varies from negative for the Cambodia simple model of care, so that's cost saving, that's where you're saving money from doing this intervention, up to $1,300 per DALI averted in Myanmar. Now, when we compare that to the World Health Organization thresholds for interventions being cost-effective, they're all cost-effective, with the only one that's been borderline is in Myanmar, and that's due to the higher drug costs and the higher lab costs in that place. We also undertook some sensitivity analyses. The emojis have changed a bit here. Where we looked at what important elements determine whether the intervention is cost effective or not. So if we first look in Kenya and Myanmar in the red squares there, it shows that the important component that could improve the cost effectiveness of the intervention in those places is reducing the DAA hepatitis C drug treatment costs, which would significantly improve the cost effectiveness of the intervention. Also, if you look in these squares, if you manage to instigate a simplified model of care, that also dramatically improves the cost effectiveness, reducing it by 2/3 in Myanmar and reducing it by half in Kenya, making it much more cost effective. These two ones also highlight the importance of improving healthcare costs. So if you remove the healthcare cost benefit in Cambodia, then the intervention is no longer cost saving. Whereas if you include it in our projections in Pakistan, then it halves your cost effectiveness, so it improves it. Lastly, in Cambodia and Pakistan, they had quite a high testing yield, which means your intervention generally is more cost effective. The higher the testing yield, you're having to test less people to get people to treat. So we looked at sensitivity analysis that what would happen if the screening prevalence was around a national prevalence level in those two countries instead of the high prevalence that we found. And in Cambodia, it reduces how cost effective it is, but it's still borderline cost saving. And in Pakistan, it increases the cost per DALI averted considerably, but is still cost effective. So in conclusions, we showed that hepatitis C testing and treatment can be cost effective in a range of lower middle income country settings. Myanmar was the only one that was borderline cost-effective, not cost-effective, but that was due to higher drug costs and lab costs, which are things that can be changed and need to be changed in that setting. They were all cost-effective when we didn't include healthcare costs averted, and however, including that improved the cost-effectiveness of the interventions and could make them cost-saving in certain instances. However, that's something we don't have much data on. What levels of care are they getting from, for their liver disease in these different places? It's hard to know. Importantly, simplifying your model of care improved the cost-effectiveness dramatically, and it can also make it cost-saving, and it caused only a tiny reduction in the effectiveness in Cambodia, while freeing up staff time dramatically. It was enabled them to scale up the number of people they could treat quite dramatically over time. And importantly, for the places that had high yields, high prevalences in their testing, we found that it was still cost effective if the screening prevalence reduced down to national prevalence levels, suggesting that these interventions could be expanded widespread in those countries and they'd still be cost effective. And here's all the collaborators, and sorry I went on a little bit.
Thank you. Please join us here. I think we'll open the floor for discussions. I would request very short questions and to also please specify who you're directing to. Yes, yes, please.
I'm Mohammed Mohsen, PhD scholar here. Actually, I was just thinking about first presentation in which you were talking about such statistics. Don't you think it's something which unfortunate that you are talking about doctors who are going to give some medications which they are not effective, and the excuses which they are giving, like only we are practicing this, and because of this we are giving antibiotics for viral infection. Don't you think it's something alarming? And second thing, about second presentation, actually issue is not with MDR, multi-drug resistant bacteria, because still we have other options and alternatives. But the statistics which you were showing, like 83% of most of the strains, they were resistant. Don't you think it's again alarming, and doctors, they should go maybe for treatment, not for normal drugs, so that they can go for second generation or third generation of cephalosporins? And I think this is the question for the doctor in first session also. Thank you.
Thank you for the question. I mean, in respect to your first part, I mean, definitely, I mean, that's why we are discussing here that yes, that much of prescription of antibiotics for viral infections is actually alarming. So if you see the OPD setups, you will find, I mean, the WHO permissible limit talks about around 30% of antibiotic prescriptions in a normal OPD setup. But we see in general in low middle income countries, I mean, it is going up to the level of 60 to 70%. So definitely, yes, it is alarming. That's why we were talking about several points which needs to be tackled. I mean, you know, there's a lot to do on that. Yeah.
Thanks for the question too. You're absolutely right. We would have loved to go for antibiotics which are not third line. Unfortunately, after culture, we try to see what drugs the patient is sensitive to, and then we go for the drugs. If the patient is not sensitive for second-line antibiotics, it makes it difficult for us to choose. And we don't even want to give antibiotics at the beginning. For patients like this, surgical intervention is the first thing. We go on debridement, 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 and we try to clean the wound. These are war wounds which happened in a very dirty condition, and they went to the hospital where the hospitals did not have enough beds to keep them longer, so they tried to wrap them up and send them. So these dirty infections that come to us, we try to clean them at one point when it's not healing at all after maybe 3-4 debridements, and with the clinical sign symptoms, then we send for culture samples. Thanks.
Good afternoon. I have a question for Dr. Amit. We have talked about this tsunami and AMR part. My question is now how to act, how to sensitize our community, and how can we bridge the gap? Thank you.
Yeah, I mean, so that's what I talked about. Thank you for the question. I mean, yes, I mean, there are two components. One is definitely hospital-based things which we can do, and then the community-based things. So in MSF setup, what we're doing right now in a hospital setting in Patna, we have started the antibiotic stewardship in terms of we are having our bacteriological reports, we are having our database in order to understand how we can minimize the prescription of antibiotics and that too rational use of antibiotics. So when we talk about so empirical treatment, definitely, I mean, this is something which is again hampering our clinical services in terms of when do we prescribe antibiotics, and empirical treatment, yes, it should be kind of reduced. But then again, it comes to, do you have antibiograms? I mean, do you have a sensitivity or resistance analysis of that particular district? No. So, you know, that's where the country right now is working towards creating surveillance units. So as part of the national antimicrobial this national plan, that there are surveillance units wherein we're getting the data and we're trying to find out what is the antibiogram for that particular area, and that would definitely help us to reduce the empirical treatment and eventually reduce the usage of antibiotics. And talking about the community-based antibiotic stewardship, that is something which has to be, I mean, it's not greatly dealt with in the national program also. So that's why, I mean, since we talked about what do we do versus informal healthcare providers versus the grassroots health workers which we already have. We have to increase the capacity of those workers so that they are confident in prescription or versus whether there is nothing to be given in terms of antibiotics. So I think the capacity building of the primary healthcare providers is the first thing, along with providing definitely the knowledge among the community you know, as part of community engagement programs that, you know, do not ask for the antibiotics, but at the same time, your primary contact points, that needs to be strengthened. Yeah, thank you.
I think we just have time for last one question. I'm sorry. Yes, ma'am. Would like to? Yeah. The quick question, please.
This is a question for Professor Vickerman. I'm going to try and be quick, but it's a little bit of a three-parter. One is, you showed that the Myanmar program was the one that had the sort of the least cost effectiveness, or the closest to the sort of the threshold of the WHO. And that was also, as I understand, the only one that was targeting specifically HIV, people living with HIV as a cohort, versus the Pakistan and Cambodia models, which were community screening. I wonder if you could talk a little bit about what that means for us as we develop our models of care, and where, therefore, things might be most cost effective as a way of providing treatment. And then I noticed that you also used a transmission model in the Kenyan context. And I wondered if you actually ran that sort of further towards elimination and looked at how, or as levels went down, kind of the impact of that on cost effectiveness.
So for Myanmar, I don't think we should read into anything that it's treating co-infected is less cost effective. It was pretty much down to the higher treatment cost that they had in Myanmar, and also the lab costs was more expensive, a number of hundred more per patient. So I think it's when you sort of have the costs similarly across the different places, and they are quite similarly cost effective, except due to differences of yield. In Cambodia and Pakistan, they had a much higher positivity rate, which we were quite surprised by, especially for co-infected. You normally expect maybe a slightly higher prevalence, and for people who inject drugs you would, but they actually had the lower prevalences. So I think for expanding, I suppose it's thinking about where you can test, where you get a reasonable prevalence, but I don't think it's not too sensitive to that. I mean, it still can be cost effective even with a reasonably low national level prevalence. So it's sort of, if you're just selecting randomly from Pakistan, then it would be cost effective, and the same in Cambodia. I haven't done projections similarly for India, but.
Okay, I know there's a lot of people still wanting to discuss, and I'm sure that you will have opportunities to talk to the individuals. I wish we had more time for more discussions. These are really two very interesting areas. And I think at the end, what we have seen is there's a lot to do in AMR, and it's not necessarily something which we expect that the governments are going to do or something was going to do it. It's a practice, it's a habit from all of us, how we influence our peers, how we influence our partners, because everybody has to contribute to the AMR control and the movement there, I think. And we have a positive note on the HCV. I mean, we have the drugs, the drug prices have come down. We have shown that evidence that it is cost effective to have a public health approach. So I think there also there's a lot of work for us to do. But we are very optimistic on that note. On that note, I'd like to close, and I'd like to thank all the speakers and the audience for active participation. Thank you very much.